So now I request Dr. SOURABH PATWARDHAN to start his presentation.
Thank you, Dr. Deepak, for including me in this wonderful IC. And I'll be speaking about how to some situations we commonly come across while dealing with the toric IELTS, and I will also add some innovative things which I have done in few cases. So, first thing I want to, as Dr. Anurag rightly pointed out, I think small pupil and toric IELTS is always a trouble because at the beginning, I think the pupil is quite dilated. By the end of the surgery, pupil becomes smaller, and in those cases, we have to improve the accuracy. So the first method to check where the toric marks are is to use the LIDRS in certain way. That means when you hydrate, in some eyes, the pupil dilates, and then you can check the marks and you can align it very well. So if those patients are there, you can use this trick. Other trick to use is to roll the eye right and left to see the marks if the pupil has become little bit of mid dilated. Here you have to take the help of the parallax basically, because iris, the IOL plane is deeper. So if you move the eye right and left, you can see those marks at the end and you can align them according to the marks that you have done. Here most of the cases I am using markerless system, but it's same when you are marked. Now this was an old case where the pupil became too small at the end after putting the IOL, and despite the adrenaline, it's not dilating. So in such case it becomes really difficult, and so I tried all the tricks, but finally I was still not sure. So in such situations, what I do nowadays is that when I am expecting that pupil is going to go down, I make these additional marks. I help the manufacturer that I am going to add two marks on either side. These are around 3.5 to 4 millimeters apart. So even if you have very small pupil at the end of the surgery, you can see those marks. And these are just, you just have to touch that needle. You don't have to, bury it. So these are like little scratch marks, don't cause any visual disturbances. And you can see here, this was a very small pupil. I removed the B hex ring, and now I am going to nudge that IOL in the axis. And you have to really look carefully. These marks are very tiny if you have made it correctly. And I will just pause here and show you how the mark. So one side the manufacturer mark is seen, but if you see, there are two tiny marks. I will just pause somewhere here, and you will see that those tiny marks, you can see, those are, so even if pupil has become smaller, we can still align it perfectly on the axis, because otherwise it is in your mind whether I have aligned the IL perfectly or not. So this is a nice trick to have in cases where you may expect that pupil is going to be even smaller and smaller when as you go. Now regarding, sometimes we have intraoperative meiosis, and then in such cases I would advise you to use a pupil expander or iris hooks, because it becomes really difficult to align the IOLs afterwards. So if you have a very small pupil to begin with, it's best that you expand the pupil, see exactly how you are placing the IOL, and I will show how to remove these expanders. So some of my colleagues told that we can remove the expanders under the hydro. It can be done, but I feel that in some cases where the pupil is really small, I will just show you in this particular case. So I have used B hex ring, I have aligned the IL perfectly. Now under the irrigation itself, I want to remove this B hex, but I have seen that in such cases we may have some iris damage as because of the irrigation coming out from the, so it maybe you can use a small side port incision or do it. But now I have changed my technique. What I do is that I use the pupil expanders, I remove everything, entire OVD, I make sure that the alignment of the IL is perfect. So right now B hex is there is OVD. I am going to first remove the OVD completely, align the IOL to the perfect axis. So now I am going to remove entire OVD, keeping the B hex at its place itself. Just as previous speaker showed, the most important part if you want to improve accuracy is remove that viscoelastic from the posterior surface of the IOL. That makes it more sticky and stick to the posterior capsule much easily. So now it's the IOL is well aligned. Now what I do, I use hyaluronate, which is a cohesive viscoelastic, in front of the IOL only, and then I remove the B hex very easily, because now AC is not going to collapse, the iris is not going to come out of the incision. And when we use hyaluronate, you just need a couple of seconds to remove that hyaluronate, and it doesn't really cause any rotation of the IOL. So this is the the way I'm doing it right now, and quite satisfied with the result. So whenever you have these small people, these are few tricks you can use, and this is a very common situation we have with toric IOLs. Okay, next I am going to speak about the iTori cap, which has already been shown by Deepak. So I will just move on how to use it. He has shown. I don't use bubble marker. I just use freehand marker. I will just show you how I mark here. Okay, so I have just done a freehand marking. No device is used. Just freehand marking, and the iTori cap will give you the final result. This is how it looks. I think Deepak has elaborated it quite well, so I don't have to go into details. So before I had Callisto, I just had these two devices, an Android phone and a marking pen. That's it. Gave me excellent results, and still gives me excellent result when Callisto is not able to register the patient. Another use of this iTori cap, even if you are using a slit lamp for doing the 0180 marking, make sure that your slit lamp is calibrated, because if you have say few degrees of error in the slit lamp itself for 0180, you may have consistently same errors in when you are marking. So you can calibrate the calibrate the slit lamp also using this app. Just put it on the slit lamp's eyepiece and take the horizontal line, check whether it is exactly 0180. This is another innovation you can use in certain cases. I will show you in one case. It was really helpful. You can take a retro illumination photograph of the patient's eye. It can be done on slit lamp, or it can be used in these UVITS autoref. They have an infrared image. So you can take those photographs. They can be used for post-operative checking of the axis. It is very accurate with iTori cap. If you have a retro illumination photos like this, you can exactly point out exact. This is very useful if you are want to rotate the eye later. So you can feed that data and you get the exact. So this was an interesting case. A young boy, I think 5-6 years old, and very high astigmatism, almost I think 4 to 5 diopter astigmatism. So I wanted to correct that, but how to mark these young boys? This at that time I didn't have a markerless system. So this was the autoref image, retro illumination image, and you can see this zonular kind of cataract. I could mark those opacities, and then I could say that these opacities are marked. I have to place the IL at 25 degrees from that axis. So this is an innovative use of iTori cap. So this is an intraoperative image. So patient is under general anesthesia. So I marked according to those opacities, which are now even seen on table in the retro illumination, and I could get a perfect alignment in this particular case. So once you have some tools in hands, of course you can utilize them in certain cases, not in all cases, but they are quite useful. Okay, you can think out of the box and then align. So you can see I have marked it on table. This is the how the IL is placed. I have done the posterior capsulotomy also, and patient did really well. I may have a post-op photograph also of this patient, where you can see that that's the post-op on the again autorefractometer retro illumination image. Axis is bang on, it's on the same axis where I had placed. Okay, just to finish, an interesting case we may come across when you are doing toric IOLs, when you get a ruptured anterior capsule. So this was an iris coloboma case, and I realized that towards the coloboma, the anterior the key CCC was actually ruptured. So there was a radial tear going towards the periphery. Now how to go about this? If you see my markerless system, I have to place the IL exactly at the same axis where there is a radial tear. So here you have to start thinking, a little laterally. So what to do next? Okay, in this case, you have to have the thought process. So the plan was, when I realized this particular IOL, see the toric marks are at the site where the haptic start. So still I have got enough equator of the lens to place the IOL. So I went ahead with this IOL itself, same plan. Patient had around 4 diopters of pre-operative astigmatism, but the way to do it is very important. So you should not allow the the anterior chamber to collapse much. That colobomatous area is already shielded by hylucoat, which is a dispersive agent, so there should not be vitreous or fluid loss there. I am going to place the IOL exactly on the same axis. So I am not going to rotate it inside the bag. I am just going to place it exactly on the same axis. And even before I remove the OVD, what I am going to do is I am going to hydrate all the incisions. I am going to use very low IOP so that there is no sudden collapse of the anterior chamber. So there should not be shift or sudden tear or posterior extension of this radial tear. That is how I am going to end this case. So of course, somebody will say this okay on table. What will happen? You know, post operatively. Of course, you have to be watchful. What is going to happen? But I will just show you 1 month post op of this patient. And these some IOLs are really good, and they stick to the bag very well. So this is 1 month post operative after the surgery. The IOL is well placed inside the bag. You can see the haptic is there. There is already fibrosis. It's not going to move. Now I have almost 2 years of follow-up of this. She is a one-eyed patient because other eye had a microphthalmos and this side iris coloboma. You can see on iTori cap also it is bang on in the same axis, and I could get away with a. Of course, we cannot use it in each and every case, but case to case wise you can take decisions. Thank you so much. So these were a few situations.
Thank you, Saurabh. Thank you for the excellent presentation. Dr. Rishi is going to speak on some of the more complex situations wherein we are going to use. As he's going to set it up, I think one tip what I would like to suggest always, I repeated just to repeat, when you're using any of these apps, either the iPhone app or the iToric app on Android, try to get the photograph with the patient on the slit lamp itself with a good illumination. It makes job much more easier. The photographs also come very nice, and you can align the circles quite very easily compared to taking it on a in the operation theater itself. That also works well, but this is much more a better way of doing it.
So
That's
what I do, of course, our phones have those torches, but we can use an external torch
Yeah.
instead of phone's torch, because many times patients are even comfortable without phone's torch because it's not coming right
Right
from
in
the
front of
center.
the
You
eye.
know, you can use the torch from side, so it will give a good illumination and good photograph. You can see even the conjunctival vessels.
And second thing is, I prefer to use speculum always, so that you get a better, wider exposure.
Okay.
You that helps in getting the perfect view of
But
everything.
I think that is for the marking you use.
Even when you're taking photograph,
Okay, that's
it is
not.
done immediately after that.
Yeah, that's really not needed. You can do
Sometimes
a,
the lead will cover the
yeah, if
superior
they have
limbus,
very
inferior
small
limbus.
palpebrals.
Yes, that's the thing. That's one thing. One small tip. And let me ask by asking the panel, what percentage of your regular surgeries do you have toric practice for the last maybe 2 years? If Bharati, you can start with this. Are you ready?
Yes.
You can just answer quickly.
Around 20 to 25% of my workflow would be toric IOLs.
Yeah, I think 30 to 35%.
I don't know whether I can put that to a percentage, but I think we did around 950 torics last year.
It must be one of the highest. And well, in percentage, maybe 35% would be okay. 35 to 40%.
Could be.
So your limit is 0.5 or above?
My level is, see, that's also interesting. I don't have a threshold for a toric selection. I put all the data that I retrieve from a patient into the toric calculator. So whenever Varian tells me that the patient is suitable for a toric, or the Barrett suite tells me that the patient is suitable for toric, and I go ahead. So out of these 950, I think we did around 130 or 140 T2s.
Okay.
So our threshold for that is very low.
Okay. So, Rishi, are you ready? Okay. Okay, fine.
So the Barrett calculator and I think the toric planning devices, and those who have got IL master, what I would advise is that make the toric IL calculation before you counsel any patient. In fact, before you see the patient, so that you exactly know whether toric IL is needed for that patient or not.
Absolutely. I think the counseling should start only after all your examination is done. The surgeon is going to decide whether this patient is going to have toric or not. So when you start talking, I think your counselor start talking. Then you should say, for your eye, this would be the best possible package or lens or whatever it is. Then you can give options, multiple.